origin, which are less important, are disorders in metabolism and endocrine, nutritional and vitamin deficiencies, bacterial diseases, blood disorders, and other diseases, for example, rheumatoid arthritis. As you know, bacterial factors are the main and most common cause of pulp diseases. As you know, there are pathways of microbial penetration into the pulp from the cavity through the dentinal tubules or directly into the exposed pulp from the periodontal packet or by the bloodstream through vessels entering from the apical foramen. Wait for a moment because I have to contact with a second your lecture, my colleague, Dr. Małgorzata. Wait for a moment, okay? Okay, so we can continue, but first of all, I want you to tell you because of Dr. Krzystanek won't lead the lecture, second one, so it will be different lecturer, Dr. Stryka-Dudziak, and you should join her new meeting, okay? So not Dr. Krzysztan planned meeting at 5:45, okay? So it was done by Dr. Strycharz. Okay, so next. What about mechanical factors? There are minor, frequently repeated, chronically acting injuries like habitual biting of hard objects and grinding of teeth, too high fillings, use of mismatched prosthetic restorations, improper movement of teeth during orthodontic treatment, and we can also distinguish acute mechanical injuries such as cracks in enamel and dentin, crown and root fractures, and tooth dislocations. What about thermal factors? Thermal factors are very important. You must know that pulp temperature range is between 25 centigrade to 42 centigrade Celsius. Both low and high temperatures conducted by the hard tissues of the tooth to the pulp can exceed the threshold of its tolerance and cause lesions. Temperatures above 42 centigrade Celsius are more harmful to the pulp. Particularly harmful are the constantly repetitive stimuli acting on exposed dentin, exposed cervical part of tooth, cavities of caries and non-caries origin, during food intake, dentin cutting, laser treatment of hard tissues and impressions masses. Temperature changes can also be conducted through fillings, especially metal fillings and extensive fillings that have no base underneath or bases when bases are too thin. The temperature in the mouth can vary from about 10 centigrade Celsius when eating, for example, ice creams, to 70 centigrade Celsius when we eat hot or drink hot liquids. Chemical factors. Numerous repetitive chemical stimuli generated during food intake, sweet, salty, sour stimuli, etc., acting on the exposed dentinal tubules. When the cavity is separated by a thick layer of healthy dentin, the stimuli will be partially neutralized in the tubular fluid. The deeper the cavity, the stronger the irritation of the pulp. Also, drugs and materials used to rebuild hard tissue defects, there are iatrogenic factors, improper use of medications and filler materials during root canal treatment. Proper of drugs consists in limiting their action only to the working area of the length of the canal. What are effects of drugs on the condition of the pulp? Phenol, it's a weak disinfect, but it's strong cytotoxic, increases dentin permeability to other harmful stimuli. When used in deep cavities, it causes damage to odontoblasts, lack of formation of secondary dentin, and inflammatory infiltrates in the pulp. Alcohol. Tomes fiber denaturation and odontoblast degeneration, and increasing dentin permeability to toxic substances. Hydrogen peroxide. When used in excess, repeated washing of the cavity, it can penetrate from deep cavities into the pulp and cause vascular embolism and circulatory disorders. The released oxygen causes an increase in pressure and vascular congestion, hyperemia. Silver nitrate. It diffuses into the dentinal tubules, combines with salts or proteins of the dentin fluid, where it precipitates in the form of silver chloride, phosphate, and proteinate. Silver salts quickly penetrate the dentin into the pulp, even penetrate the sclerotic and secondary dentin. In medium and deep cavities, it causes degeneration of odontoblasts and adjacent parts of the pulp and inflammation. When silver nitrate is applied, silver particles are present throughout the pulp and even in the periodontium. Influence of materials used to fill cavities on pulp conditions. What is toxic to the pulp? Silic acid from silicon cements is highly damaging to the pulp. Fortunately, they are currently not used. Silicon phosphate cement, chemocurable composite material of the older generation, especially those in which the main component of the basic substance is polymetal methacrylate. Free monomer from older generation composite materials like metal methacrylate, benzoyl peroxide, and free monomer from self-polymerizing acrylic resins. They are most toxic to pulp. And when we have free monomer, MMA, and free monomer plus bacteria, which they penetrating under the filling of older generation composites, they transfer of nuclei or entire dentin forming cells into dentin tubules. It causes degeneration of the odontoblast layer, inhibition of second. It causes congestion, vascular rupture, abscesses, and foci of necrosis in the pulp, and at the end, chronic purulent inflammation of periradicular tissues. What is toxicity of contemporary composite materials? When we're discussing the problem of possible toxicity of composite materials, we take into account three facts. Dentin is a protective barrier for the pulp. Both toxic chemicals contained in materials and microbes entering via microleakage can cause iatrogenic lesions in the pulp. The base at the bottom of the cavity, regardless of the type of thread, is a more effective protective barrier for the living pulp than it is. Dentin is a protective barrier for the pulp because it's a physical barrier. The thicker the dentin layer, for example, the shallower the cavity, the longer the pulp path to the pulp, the lower the danger of chemicals reaching the pulp into the chamber. The deeper the cavity, the greater the penetration of the substance into the pulp. The pressure inside the pulp opposes the penetration of toxic substances. And dentin as a chemical barrier. Dentin proteins can bind toxic substances contained in adhesive systems and composites. And dentin permeability depends on the patient's age. In male teeth and in deciduous teeth, the of dentin barrier is much lower than in adults. Thin layer of hard tooth tissues, large dimensions of the pulp chamber, wide lumen of dentin tubules, acute course of caries, not conducive to the formation of protective layers, sclerotic and secondary dentin. The outer layers of dentin located near the enamel are less permeable than those adjacent to the pulp. The diameter of the lumen of the tubules is about 3 times smaller than near the chamber. The number of tubules per unit dentin area increases as it approaches the tooth chamber. In the process of filling cavities with composite materials, in accordance with the principles of the technique, several factors are created that can potentially cause the appearance of lesions in the pulp. What about etching? We must remember that acid etching of dentin is routinely performed to remove the smear layer, the presence of which prevents good adhesion of the composite to the enamel and dentin. The removal of the smear layer is accompanied by demineralization and widening of the lumen of the tubules, which become more permeable to the chemicals contained in the binding systems and microbes or their toxins, which can penetrate deep into the dentin and then into the pulp. This treatment is generally considered to be harmless to the pulp if there is a base at the bottom of the cavity. Currently, a short 15-second etching is recommended, which partially removes the smear layer while maintaining its protective function for the pulp. What about toxicity of bonding system? Some dentin bonding systems are more toxic than the composites themselves, some of which have a toxicity to that of their counterparts. This greater toxicity of bean systems is related to their thin consistency. As a result, they penetrate relatively deep into the dentinal tubules, whether do not polymerize completely in the present tissue fluid and therefore contain a large amount of chamber dentin wall should be isolated base. In the light of many years of observation, the application of the base on the chamber dentin wall be isolated with the base. In the light of many years of observation, the application of the base does not damage the condition for maintaining the filling. Organic components, residual monomers, are considered toxic in composite material. Toxic bisphenol A can be released from these compounds. The components of the composite, such as inhibitors, accelerators, photoinitiators, or photostabilizers, are also irritating. Toxic compounds are released from composite material both during their polymerization and much later in the process of aging of the filling in the oral cavity, hydrolyzation, degradation by microorganisms entering by microleakage from dental plaque. Newer generation composite materials are less toxic to pulp than previously produced chemically hardened materials. The toxicity of all light curing composites with a similar content of organic and inorganic substances is similar. Composites can cause moderate changes in the pulp, hydronic degeneration of the odontoblast layer, acute pulpitis turning into chronic pulpitis with fibrosis. Non-polymerized are only partially polymerized materials show greater toxicity. Accurate polymerization of the filling, the appropriate quality of the lamp, and the layered application of the material plays an important role in the prevention of pulp damage. Effect of composite materials on bacterial metabolism. Composite materials stimulate the growth of bacteria found in dental plaque and microleakage. The stimulation of bacterial growth is attributed to the components contained in the organic phase of the composite, monomers, and a tertiary amine. Bacterial enzymes are capable of hydrolyzing or altering the ester bonds of polymers. During this depolymerization, free monomers toxic to the pulp are released, metabolized by microorganisms. Effect of microleakage on the condition of dental pulp. When there is polymerization shrinking, then form marginal fissure, and we have microleakage and penetration of bacteria causing lesions in the pulp. As a result of microleakage, bacteria and their toxins penetrate the pulp through the dentinal tubules, causing inflammatory changes in the pulp. Proper filling of the cavity in accordance with the manufacturer's recommendation reduces the effects of microleakage as a result of polymerization shrinkage. Is it possible to avoid marginal gaps and microleakage by using composites together with dentin and enamel bonding system? A tight connection of the composite material can be achieved in cavities surrounded by enamel. The durability of the tightness of such a filling depends on the stability of the adhesive system. The filling will remain sealed until the adhesive system is in clinical conditions. The stabilization period of bonding system is influenced by the composition of the material, the class of the cavity, and the state of oral hygiene. With abundant plaque accumulation containing a lot of microorganisms, the adhesive system will break down much faster. However, it is not possible to obtain a tight composite filling in the cavity when one of the edges is located within the dentin and cementum, because in the area of dentin and cement, the polymerization shrinkage forces exceed the adhesion forces in class 5, 3, and 2 cavities. The role of bases in the prevention of pulp disease. With the base or without the base? Underlayment materials should be characterized by good marginal adhesion to dentin, the ability to form chemical adhesion, the bonding of substrate material molecules with organic and inorganic dentin molecules. Good marginal adhesion protects the pulp from the penetration of toxic agents from the composites, as well as microorganisms that may have entered with the microleakage. Impermeability to chemicals, microorganisms, and their toxins, an important role in preventing the penetration of the above-mentioned factors is played by the homogeneous structure of the base and its antibacterial properties. And good material, good base, should have low activity, a bad conductor of thermal stimuli, because filling material, especially metal ones, conduct heat well. The danger of damaging the pulp by high temperature is greater than by low temperature. Drinking hot beverages raises the temperature of metal fillings to about 80 centigrade Celsius, eating ice cream to 12 centigrade Celsius. Resistance to mechanical forces, pressure, bending, appropriate hardness, and the high value of Young's modulus. A resistance of bases to mechanical forces and high value of modulus ensures resistance to cracking and fracture. The coefficient of thermal expansion is similar to that of dental tissues. The ability to retain volume under the influence of thermal and mechanical factors. The high value of Young's modulus and the expansion coefficient, similar to that of dental tissues, protect the pulp from the harmful phenomenon of percolation. Percolation phenomenon. The phenomenon of percolation is based on the fact that if the dentin is not isolated with a primer, then under the influence of changes in the volume of fillings occurring with large fluctuations in oral temperature. Under the influence of chewing forces, and especially when the fillings are too high, resulting from the properties of the material, the lower the modulus E of the filling, the more it deforms. The effect of the pump is alternating between suction, movement of fluid in the direction of the cavity, and injection into the dentin fluid, which leads to changes in hydrostatic pressure in the dentinal tubules. The change in pressure is harmful to the pulp and odontoblasts. Composite materials and amalgams have a higher coefficient of thermal expansion. Under the influence of temperature, they contract and expand to a greater extent than hard tissues, which leads to widening of marginal fissures. During the operation of the pump, microorganisms from the oral cavity environment can therefore penetrate through the gaps under the filling. The increase in pressure leads to dentin fluid flowing up and accumulating under the base. Damage to the pulp caused by changes in hydrostatic pressure in the tubules is manifested by symptoms of post-operative hypersensitivity and sometimes even spontaneous pain. Chemical resistance, insolubility of bases in aqueous solution, and their resistance to acids used for etching enamel and denting. The last feature of good material, chemical resistance. In deep cavities, additional layers, liners, should be applied under carboxylic and glasionomer cements, and these are preparations based on calcium hydroxide. Another factors which can cause damage in the pulp are electrochemical factors. As you know, the presence of two different metals with different electrochemical potentials in the oral cavity, for example, amalgam and gold fillings, causes the formation of galvanic currents that can cause changes in the pulp. Iatrogenic factors. These are pathogens for the pulp and periradicular tissues which arise unintentionally during dental procedures performed by a doctor. Iatrogenic pulpotitis are caused by the cumulative action of iatrogenic, mechanical, thermal, chemical, and osmotic factors. Iatrogenic factors are the third most common cause of pulp diseases after caries and injuries. Iatrogenic diseases of periradicular tissues can be caused by one type of stimulus or the sum of several types of stimuli. Often, mechanical factors work in conjunction with or chemical. Iatrogenic bacterial factors, introduction of bacteria into the pulp through the open dentinal tubules of during prosthetic impressions, teeth that have been ground before permanent prosthetic restorations, a place should be protected against the penetration of microorganisms, thermal and chemical injuries with appropriate varnishes and tight temporary crowns. Accidental pushing of necrotic masses outside the apical foramen of working with infected endodontic instruments outside the area of the working length of the canal. Also, unnecessary prolongation of endodontic treatment and multiple application of root canal temporary fillings, unjustified use of the so-called open treatment in causes of acute purulent inflammation of periradicular tissues. Iatrogenic mechanical injuries, for example, cutting dentin with high speed, low speed, and turbine drills and using a high energy laser induce changes in the pulp. When is dentin cutting, it created opening of the lumen of the dentinal tubules and breaking the continuity of Tom's fibers. Mechanical injuries occurring during improperly performed endodontic treatment in the absence of determination of the working length of the canal and or work with non-calibrated instruments cause exceeding the boundary of the physiological opening and damage to the mixed pulp periodontal tissue. Dentin lesions. Breaking the continuity of tone fibers, evaporation from dentin fluid tubules and dentin dehydration, protein coagulation, change in osmotic pressure in tubules, pulling nuclei of odontoblasts or whole odontoblasts into tubules. Rotation speed. The greatest damage to odontoblasts occurs at speed about 50,000 rpm per minute, even when refrigerated. It is recommended to use ultra-fast rotations to remove enamel and superficial dentin layers. Dissection of the bottom of the cavity lying close to the pulp should be performed at a very low speed. Cavity depth. The extent of the lesions in the pulp is always proportional to the depth of the prepared cavity. The deeper the dentin cut moves towards the pulp, the greater the damage to the odontoblasts and the more extensive the inflammatory reaction. Cutting the superficial layers of dentin in the area of the enamel dentin junction causes weak irritation and stimulates the formation of secondary dentin. Cutting dentin only 0.5 millimeter wide from the pulp, especially with fast rotations, usually damages the odontoblast and disrupts the process of secondary dentin formation. Extent of cut dentin surface. Compared to small cavities, the preparation of extensive cavities results in damage to more Tom's fibers and odontoblasts, and thus to larger areas of the pulp. It is particularly irritating for the pulp to perform preventive widening of cavities, as it exposes dentin tubules under which there are no protective layers and secondary dentin. Vibrations. They appear when working with any type of drill. The frequency and power increase as the speed of rotation increases. They can cause changes in the pulp, irreversible disorders in cell metabolism and edema, inflammation, cell degeneration, fibrous degeneration of the intercellular substance, and disorders in the formation of secondary dentin. Periodontal treatment. Deep curettage can mechanically damage blood vessels penetrating through the lateral accessory channels, resulting in limited lesions in the pulp. Tooth sensitivity after this type of treatment may be caused by exposure of the roots, but also by circulatory disorders and hemorrhages in the root canal pulp. Improperly selected drugs used to relieve sensitivity of exposed roots can penetrate the lateral canals and may aggravate changes in the pulp. Moving teeth too quickly during orthodontic treatment. It can be a mechanical injury leading to circulatory disorder and hemorrhages. Resorption of apical roots can cause changes in the pulp, as evidenced by the frequent hypersensitivity of the teeth to external stimuli. Surgery, extractions, resections, surgeries of tumors and cysts create the possibility of unintentional mechanical damage to the vascular bundle of adjacent teeth. Chronic injuries, too high fillings, parafunctions in the form of biting on a foreign body, biting on a pen, biting on a thread. Iatrogenic thermal stimuli, high temperatures are generated during cavity preparation, polishing fillings, or preparing teeth for crowns. The amount of heat generated depends on rotation, speed, drill press force, type of cooling, the size of the drill bit and the material from which it is made, contact time of the tool with dentin. Thermal damage to periradicular tissue can occur when the temperature in the periodontium, cement, or alveolar bone rises to about 47 centigrade per Celsius. Exceeding this critical temperature can lead to damage to the apical periodontium in the form of necrosis, foci of resorption in bone and cement, and ankylosis. Thermal damage to periradicular tissue may occur when grinding teeth without vital pulp, when disinfection root canals with a laser, in the case of canal filling techniques with thermally plasticized gutta-percha, after preparing the place for the crown root inlet, when removing retention elements, broken root rotation speed and drill force. As the speed of rotation of the drill and the force applied to the drills increase, friction increases, resulting in an increase in temperature. When working with high-speed drills, use the technique of gentle short-term charges. The heat generated when cutting dentin is largely eliminated by cooling. Cutting dentin without cooling, even in medium deep cavities, can cause inflammatory changes. Water cooling is more effective than air cooling. The water jet should be directed directly at the point of contact between the drill bit and the tooth tissue. A temperature increase of 6.5 degrees can cause changes in the pulp. Air cooling is an irritant. The airflow directed at the exposed dentin causes the dentin fluid to evaporate from the tubules, which in turn causes the odontoblast nuclei to move dentin to die. Size of cutting tools. Cutting dentin with large drill causes a greater increase in temperature than cutting with smaller drill. Dentin incision should be carried out with sharp drills that are significantly smaller than the diameter of the cavity. The greatest increase in temperature occurs when working with a steel drill, less with carborundum and diamond drills. High energy, they carry the risk of thermal trauma. Iatrogenic light and radioactive stimuli. UV lamps used for therapeutic purposes in the facial part of the skull, neuralgia, periodontal and temporomandibular joint diseases, and teeth whitening. Radiotherapy of cancer in the head and neck, damage to the alveolar bone, periodontal bone, and the pulp. Allergic factors. Dead pulp, of proteins that were part of its cells, fibers, or basic substance, cause them to take on the properties of an antigens. Antigens coming out of the canal to the periradicular tissue cause sensitization and the production of antibodies directed against the host tissue after they are absorbed by the vessel. I want to add about retrograde changes of the pulp and progressive changes of the pulp. To retrograde changes of the pulp, there are degenerations of the pulp concerns all the pulp or only the layer of odontoblast, and we have vacuolar, fatty, hyaline, calcium, and fibrous degeneration. Vacuolar degeneration occurs in most cases in odontoblast cells. It's considered as the earliest symptom of odontoblast because of irritation or Hart-Thomp's process. Another retrograde changes are denticles. There are large calcium mineral deposits. They form in the course of chronic pulp inflammation, and after conservative treatment, they form in places of necrotic foci. They are located in pulp's chamber as well as in the pulp in root canal. They come in different sizes. Most often they are asymptomatic. If they occur in the vicinity of nerve fibers, they may cause compression of nerve endings and cause symptoms of spontaneous pain. Their presence may complicate endodontic treatment. Another retrograde changes of the pulp. A pulp atrophy, it's a gradual decrease in the volume of the pulp due to the reduction of its components. We have physiologic atrophy, it's a physiological result, and a senile atrophy resulting from filling the tooth cavity with secondary dentin, and pathological atrophy reasons, for example, overloaded teeth, resolution of chronic inflammation and degeneration of the pulp. Another retrograde change is necrosis pulp. It's a dissolving necrosis colliquativa, humida in Latin. The pulp takes the form of a soft, mushy mass or takes the form of a thick gray-brown or gray-green liquid, often found in primary and permanent teeth during development. And second type of necrosis is necrosis coagulativa, sicta in the Latin. The pulp takes the form of harder consistency and looks like white-yellow dry thread. Dry necrosis occurs much more often in older people with a narrow apical foramen and in the presence of pre-existing degenerative changes. Another, gangrena pulpa. Gangrene is a form of necrosis that occurs when anaerobic bacteria get into the necrotic pulp. In addition to the appearance characteristic of necrosis, a putrid smell appears. Necrosis can be complete or partial. Necrosis may occur in a closed or open chamber. If it takes place with the chamber open, it may occur without subjective pain symptoms. And progressive changes of the pulp, there are non-physiological secondary dentin, pathological dentin, is formed under the influence of external irritating pathological stimuli acting directly on exposed dentin. And pathological dentin is characterized by a more irregular structure than secondary physiological dentin. And reparative dentin, a dentin bridge is formed under a biological treatment of exposures, wound after vulneration or vital amputation of the pulp. And thank you for your attention, and please join